Thank you very much, Dr. Schuler, and thank you for the retina community here in Pensacola to invite me to stand in front of you and talk about a subject that is dear to my heart. I chose the subject to talk about hypertension for a few reasons. Number one, it is a silent illness and also called the silent killer. And I did not put this for commercial advertisement. I put this that if you have a Facebook and you want a copy of this presentation live, or you want few essential slides, I've already uploaded a couple of slides on there that are I will mention as I go along. So you can log in and like us, the virtual nephrologist, and then you can see those slides. So I will talk about hypertension, and I made this presentation to be extremely helpful to every person who is here in this room that can and has been dealing with the hypertension as well. About 30 years ago, when I started medical school, we thought hypertension was a vascular disease. So what we thought is the blood vessels are sick, and that leads to end organ damage. Eventually, further research, we knew that it is not only the blood pressure that is the cause of the end organ damage, but also the blood vessels. So the blood vessels in by themselves get diseased, and that would eventually lead to end organ damage. Being ophthalmologist, optometrist, and other healthcare providers, everybody's familiar with the vascular and vasculopathy that occurs with retinal disease and hypertension. We know today, after 30 years of hard work on hypertension, that the origin of hypertension is actually the endothelium, which is the lining inside the blood vessels that really is the source of the illness. Now, I have a challenge right now is all of you had lunch and really maybe sleepy a little bit. So I'm not going to be talking about endothelium and biochemical pathways. I'm going to be talking about real stuff and day-to-day medicine. So hypertension is really a vascular endothelial disorder, and really it is a disease that is not equivalent to the term high blood pressure. High blood pressure is a vital sign, meaning that you take somebody, you sit him on a chair, you get to measure the blood pressure, and that is a blood pressure reading, which is a vital sign. Whereas hypertension is actually a disease. And that disease, one of its biomarkers is elevated blood pressure. So if you are diagnosed with hypertension and take your medicines on time, and your blood pressure is 120/70, does it mean you don't have hypertension? The answer is no. You do have hypertension, but your blood pressure is under well control. So I want you to really understand the difference between hypertension and high blood pressure. The ICD-9-10, the ICD-10 for that diagnosis is I-10, and it's not a joke. And it's not the interstate, it is I-10. You look it up. That is the ICD-10 for hypertension. It is the most common disease on the face of this earth, and hypertension or hypertension complication is the most common cause of death worldwide. 1 out of 3 American adults have hypertension. So I look at this room, probably I would say 20 will have hypertension, and 1 billion people worldwide have hypertension. So I chose a subspecialty in nephrology called hypertension because I know I have a lot of patients to see. Now, how good of a job we are doing. This is called the NHANES data. The NHANES data look at how good we are recognizing, treating, and achieving blood pressure control in African American, non-African American, and Mexican Americans. And if you notice, the control of the blood pressure in white people is better than the African American, and the percentage-wise is better than the Mexican American. So the nephrology and the hypertension community have an obligation to really look and make extra effort to address blood pressure. When we talk about what is the definition of hypertension and what is the number, remember high blood pressure is a vital sign and it's a biometric measurement. Hypertension is a disease. So when we look at measuring the blood pressure, when we say 120/80, that is a normal blood pressure. This is fairly high normal, and this is hypertension. Now, most of the medical communities recommend recheck within 1 year or recheck within 6 months. I have to disagree and I have to differ with this. The reason is when you have the diagnosis of hypertension, where the blood pressure is above 120/80, the pre-hypertension area, or actually hypertension, you can measure your blood pressure as frequently as going to the gas station. There is a blood pressure machine at Walmart, there's a blood pressure machine at Publix, there's a blood pressure machine at CVS. All these entities have easy access to the blood pressure machine, so you can measure it frequently and make sure you don't wait a year worth of elevated blood pressure and then recheck it again. So, who is at risk for hypertension? Now, I showed this because this is very complex, so I thought I'd make it very confusing and complicated. Or we can simplify this and talk about genetic factors. Age. As we age, we have an increased risk of hypertension. People who are 10 years old, the odds are they having hypertension is almost zero. Whereas if you're 70 or 80 years old, most likely you will have hypertension. Males have more chance of having hypertension than females. Keep in mind, this ratio will reverse at age 50. Estrogen and progesterone are very protective against hypertension in women. Once they reach the age of 50 or have a hysterectomy and oophorectomy, they lose the protective effect of estrogen and progesterone, and they tend to become hypertensive. Ethnicity, African Americans, Mexican Americans, Native Indians have a more chance of having hypertension than Caucasians. So that is not a choice. And some families actually within the same ethnicity have higher blood pressure than others. If you are white American and you're of Italian origin, the chances are you have less hypertension than if you are of German origin, and we don't know why, whether it has to do with the family, whether it has to do with the olive oil or the red wine versus beer, I don't know. Then when we talk about environmental factors, you can summarize environmental factors with this slide. As we moved into urbanization and civilization, things have really gotten easier for us, more convenient for us, but that really reflected on many diseases. So when we talk about obesity, when talking about sedentary lifestyle, talk about alcohol, we're talking about salt, sleep apnea, obesity, lack of activity, all these are risk factors, acquired environmental risk factors that lead to hypertension. Then when we, as a hypertension specialist, when I see patients with hypertension, in my mind, the first thing that comes to mind is this primary hypertension, meaning that 90% of the patients who have hypertension is primary. They are in their 50s, now they put on an extra 20 pounds, they're no longer doing this, they're eating a little bit more of that, and so forth. So this is primary hypertension versus secondary, which happens in a out of the norm. So you will see somebody 16 years old that has severe hypertension. And that's the time where we as physicians have to investigate, is this the regular hypertension that happened to most of the people, or this is unique and different? Then there's another entity called resistant hypertension, where a patient takes at least 3 different medicines and the blood pressure is still 220/120. So in our minds, really these are categories that we pay attention to. What are the symptoms and signs of hypertension? It is mostly silent in most of the times, and really sometimes patients would have about strange complaints. And keep in mind, we as healthcare provider have to take every patient with true face value and take him seriously. Because some people may complain about hypertension totally different than others. Some people would say, my ears were ringing. Others would say, I have a headache up here. Some people say, well, the top of my brain is burning. I hear a train in my ears. My fingers are numb. My face is flushed. My ears are flushed. Different things. So really, we have to take that in a very, very serious way and really look at it and prove that is not the case. So how do we check blood pressure? And this is a brochure that is already uploaded to the Facebook, The Virtual Nephrologist. One time I was at the office, and there was a young lady who was 27 years old who was told that she had hypertension, and she refused to believe that, so she was referred by her primary care doctor to me to talk about hypertension and to see if she truly has hypertension and whether she needs to be taking medicines or not, because every time her blood pressure is 160 over 110. So I said, okay, let's check your blood pressure and let's see, you need to come to the office when I'm not at the office wearing a white jacket so you can be relaxed and we can check your blood pressure. So the nurse, my nurse calls me and texts me and she says, Miss So-and-so blood pressure is 192 over 100. I said, wow. But she said to me, please hurry up, check my blood pressure because the car is still running outside. There are 2 kids and my baby is there and the dog is there and I really, really need to hurry up so I can get my blood pressure checked. This is not the right way to check the blood pressure. So when you check your blood pressure, you have to have and follow certain guidelines. You have to be seated and relaxed for at least 5 minutes. You have to be comfortable and you do not have to have any distractions. Don't take your blood pressure after exercise, or you smoked a cigarette, or taken a big meal. Do not use wrist monitors, and do not take it while you're exercising. And sit down at a table, left arm at the desk. Sit at a table, you can support your arm and have a blood pressure cuff that really wraps on your bare arm. Rest it at a heart level and keep your feet and your ankles on the floor and do not cross your legs. That is sometimes a very common practice. Especially women, they come in, the first thing they do when they sit to check your blood pressure is cross their legs. And when they cross their legs, they squeeze the blood vessels in their legs and the blood goes up and then fill up their blood vasculature, and that leads to elevation in their blood pressure. The other thing, and that's what we tell people when they're about to feel passing out, just cross their legs and squeeze so they can elevate their blood pressure. So very important not to cross your legs. Now, somebody comes to the office and they want to have, yes ma'am?
What's wrong with wrist monitors?
Wrist monitors have not been standardized. What I mean by this, when we, the medical and hypertension community, decide to treat and decide to categorize blood pressure readings, they are based on the standard way: seated, uncrossed legs, comfortable, arm monitor. So when we use wrist monitors, they have not been checked. There is an agency in the United States called AAMI, American Association of Medical Instrumentation. Every device has been calibrated. Most of the wrist monitors are made in China. So we don't know when that reads 120 over 70, what is your true systolic blood pressure. So what ends up happening, we get to treat based on an inaccurate data, so we make wrong decisions. And I totally discourage the use of wrist monitors. Thank you, that was a good question. So somebody comes into the office, was as referral from their primary care provider, or they walk into the office and say, I have hypertension. We don't say, okay, take these 2 pills and I'll see you next month or next week. We have to do certain basic investigations, and these are electrolytes: sodium, potassium, calcium, and magnesium. Our diet is very deficient in magnesium, and sometimes the blood levels of magnesium are fairly low. and that can lead to hypertension. So rather than giving them a blood pressure pill, we will tell them eat more walnuts, eat more figs, take over-the-counter magnesium pill will help with blood pressure. Same with potassium and calcium. We always measure the kidney function. Patients with kidney disease will have elevated blood pressure, and sometimes the first finding of their kidney disease is an elevated blood pressure. So they come to us and we do the blood work and we find kidney disease. Uric acid and gout. This is important because some blood pressure medication will make your uric acid worse. So if you have a patient that has gout or has a tendency to have gout and their uric acid is already elevated and we did not know this and we put them on a certain medication, will make the uric acid worse and they will get gouty attacks. And people who do not know what gout is, it is a painful, painful disease. The nickname for it on the street is gouch. So it's called the gouch disease. Thyroid disorder. Sometimes this is a great opportunity for us to recognize thyroid disorder for patients. Both overactive and underactive thyroid will lead to hypertension. So we really screen for both thyroid function, fasting lipids, and sometimes patients have severe hypertriglyceridemia, and you probably have seen at one time the retina and the vasculature to look like milk or maybe milkshake if the triglycerides are extremely elevated. Fasting blood glucose and hemoglobin A1C. It is estimated that 10% of cardiovascular events that occur in the hospital, like a heart attack or a stroke, are for patients who don't know they're diabetic. And diabetes in by itself is a risk factor, so the first presentation of diabetes can be a heart attack or can be a referral to the nephrologist or the hypertension specialist. Now, there are certain guidelines. Patients over the age of 45 that have a BMI over 25, they deserve to have a screening test for diabetes. So we include that in our evaluation for hypertension. Vitamin D levels. Today, we know that vitamin D has more than 1,800 different receptors, other than the bones and the aches and pains. Fibromyalgia will do well with vitamin D, hypertension, retinopathy, diabetic retinopathy, heart disease, dementia, cancer prevention. All that is mediated by vitamin D. So we measure vitamin D level and correct if they're deficient. EKG is also essential, and a kidney ultrasound, and a sleep study. We know today also obstructive sleep apnea is an extremely high risk factor for hypertension, and it's very undiagnosed and underdiagnosed. And it happens more commonly in men. And the theory behind it, and this is evolutionary theory, is that men are the one at the time of the caves, rather than houses, at the time of caves, were the protectors. So they slept right at the entrance to the cave. And they were so tired and snored so loud, so any beast that come close wanted to eat the wife and the kids will hear that snoring, will say, no, 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 no. There may be a bigger beast in there, so we need not to come close. So, but this is an imaginary evolutionary theory. When we talk about resistant hypertension, they need to be taken at least 3 different antihypertensive agents, one of them to be a diuretic, and then they will be defined as resistant, and then we would look for secondary causes: thyroid, sleep apnea, vascular disease, certain medications, over-the-counter medications like nonsteroidals, birth control pills, weight loss products, ephedrine. All those can lead to secondary hypertension. What are the complications of hypertension? Remember, I mentioned hypertension is the most common cause, hypertension and its complications, most common cause of death worldwide. Hypertensive heart disease, hypertensive strokes, hypertensive TIAs, dementia, kidney disease, peripheral vascular disease, an aneurysm. Rodney Dangerfield, I don't know if anybody remember who that is. He died of an aneurysm related to hypertension, hypertensive retinopathy, and erectile dysfunction in young men. Now, this is something that I know that you do every day, and I taught myself how to recognize early signs of hypertension and advanced hypertension. Keep in mind, this is an invitation to treat. AV nicking and a change in the arterial colors, whether it's silver or copper. I can't tell that very well, but I can tell the nicking. And that is an evidence of end organ damage. I don't need to do a heart ultrasound or an artery biopsy to know there is end organ damage. I can see it. Now, the difference between this and this is a cause for an admission to the ICU, because I see there is a loss of autoregulation of the blood vessels, and what is happening here could happen in the brain, could happen in the kidneys, which is the flame hemorrhages, and that is a reason to be admitted to the ICU and be placed on tight blood pressure control. Otherwise, what happens here could happen in the heart, could happen in the brain, and can lead to massive strokes. So if blood pressure is not treated, we can have brain hemorrhages and strokes, congestive heart failure, dialysis, peripheral vascular disease, or dementia. And I did not know, or I chose not to put the erectile dysfunction in men's picture. So what is the target for blood pressure when we treat? A lot of times patients come and say, so doc, you're giving me this pill. I was feeling fine before, and now I feel bad with this pill. And I don't know, it was 150 last week, and now it's 130 over 80. And I just feel bad, pay $100 a month in my copay, and I don't know what you're doing. So where do you want my blood pressure to be? Well, in general guidelines, it has to be less than 140 over 90 if somebody has no other reasons. But if you have kidney disease or diabetes or additional risk factors, heart disease, the target has to be lower and lower. And the reason is every 2 millimeters decrease, 2 millimeters, decrease in the blood pressure, in the systolic blood pressure, there is a 7% reduction in ischemic heart disease mortality. Mortality is death. Mortality is body bags. Mortality is a funeral. 2%, 2 millimeters reduction in a systolic blood pressure will give you a 7% reduction in mortality and a 10% reduction in the risk of stroke mortality. This is an unbelievable statistics, and this is not 20 patients out of Timbuktu. This is 61 prospective studies analysis, about 1 million patients. So we know today that tighter the blood pressure control, we are doing a lot of favors for our patients. So, yeah, doc, I'm good. My blood pressure is 150 over 90, and that's okay with me. You take him to 150 to 140, you multiply that by 5, 35% reduction in ischemic heart disease mortality. That is unbelievable statistic. So really, we need to take blood pressure control in a very serious manner. Now, when we talk about treatment, and this is a fairly dense slide, what I wanted to tell you is the treatment has to be not only medication, but has to be other factors. Sometimes we wait for lifestyle modification before we treat those patients. So we check a blood pressure initially and decide if a patient has compelling reasons or no compelling reasons. And again, this is a busy slide, but I wanted to show that to you, to share with you that we start with aggressive lifestyle modification. Remember the slide initially when the man was sitting in a chair with a remote, watching a football game with a beer and a bag of chips? All these we have to reverse, and we have to be able to stop so we can really make a difference in lifestyle modification. Government and CDC have something called the DASH eating plan. Dietary approach to stop hypertension. It's published everywhere. All the nephrology community, hypertension community have endorsed this aggressively, the DASH eating plan. And it's basically really just good, healthy food and not the fried chicken and the biscuits and the gravy and the bacon in the morning. So it talks about fruits, vegetables, grains, healthy starches, and nuts. Again, the non-pharmacological intervention, lifestyle modification, diet, exercise, reduce sodium intake. On average, how much sodium are we allowed to eat a day? About 2 to 3 grams of sodium a day, which is 2,000 to 3,000 milligrams. How about a bag of potato chips? How much sodium does it have? Probably about 1,000. And how about a small-sized French fries from the fast foods? 1,500. So now you just had a small fries and a bag of chips, and you took everything you have to take or you need to take in a 24 hours period from sodium intake. American average diet has about 8 grams. So we, on average, eat 3 times the allowable amount of sodium for adults in the United States. Other places even eat more. In India and in the Philippines, they eat more sodium. But on average, the body needs 2,500 milligrams in a 24 hours period to function and do well. So we need to reduce our sodium intake, smoking cessation, and discontinue alcohol consumption, magnesium and potassium. And sometimes we can talk about alternative medical therapies to treat hypertension and vascular disease. This is a whole lecture in by itself, but a few things that work. CoQ10, magnesium, turmeric, they work for hypertension and as well. So we did repetitive blood evaluations, blood pressure evaluations, whether at home, at the doctor's office, at CVS, and the patient brought in a list with them, and they have the diagnosis of hypertension. It's not only high blood pressure. Remember, high blood pressure is a vital sign. Hypertension is a disease. So we established they have the disease. We've done their blood work and everything looks okay. So this is a patient who's about 55 years old, executive, just aged, and is 1 out of 3 American adults with hypertension. They did what they needed to do. They exercised, stopped the boiled peanuts, and cut down the beer, and just kind of did exactly what needs to do, and the blood pressure is still elevated. 142 over 92. Would you put them on medications? I want to see hands. So you would take medications. 142 over 92. Did everything that needs to do before medications. Nobody would treat him? How many? 1, 2, 3, 4. Why? 2 points will do what? By 10. I'm glad you remembered now. Every 2 points, every 2 millimeters of mercury drop in the blood pressure will reduce ischemic heart disease mortality by 10% and stroke mortality by 10%. That is great statistics. Remember, he's a man and middle-aged man, so really they're at risk of having heart disease. So, yes, I would treat them. Now, would I treat them with 1 pill or would I treat them with 3 pills? Here is what we learned today. If somebody has uncontrolled hypertension and then we give them a pill and the blood pressure is still elevated, and I say, okay, so you're taking half a pill in the morning. How about if you take the whole pill all day? So we really, basically, we doubled their medicine. So what is happening when we double medicine, they have increase in the side effects. Once they have increase in their side effects, the patients will hate that medicine, so either going to stop it or cut it in half. So now we're back at square one. Blood pressure is still not controlled, and we're right here. So the theory now is you have to take a little bit of this a little bit of this, a little bit of this, so that we will have the best therapeutic effect with the least side effects. Because every medicine has a side effect, including if your medicine is an M&M. What do M&M do? They don't do anything to you. They do something to your clothes. They make your clothes tighter. So, on average, how many pills for blood pressure a normal person will need? This is a study looking at different groups of studies regarding hypertension, and we found today an average white person will need 3.2 pills of different classes to control their blood pressure. And if you're African American, 3.9 pills to control the blood pressure. So if you have hypertension, or if your cousin or your patient said, well, you know what, I've been going to Dr. Rafai, he doesn't seem to make up his mind because I've taken this pill and I went back to him and my blood pressure is still elevated. And he said, take more of a different pill. And then he gives me another pill. What is he thinking? Because on average, a white person will need 3.2 pills. A black person will need 3.9 pills to control their blood pressure. Because we don't want to use one pill to the maximum dose. You'll have every side effect is listed in the PDR. We want to use a little bit of this, a little bit of this, a little bit of this, so we can achieve good blood pressure control. A lot of times, we have to also share with our patients that these medications can lead and can have side effects. So we have to mention that to them because it's very important. Your patient consent to edema, one of the classes of medications called calcium channel blockers. 50% of the patients will have swelling in their ankles. So if you are somebody who likes to wear high heels, you know that'll be gone. So you have to tell your patients this medicine can lead to edema and you will lose the opportunity to wear your high heels. Some other patients, young men, we put them on a certain class of medication, beta blocker. The next thing is erectile dysfunction. So we really need to share with our patients the side effects so they can really make a conscious decision which class of medications they will take. High blood pressure management is actually an art. It's not a science. Because if you read the PDR, there's 150 different classes and brands of medication for the treatment of hypertension. It's just like you open your cupboard and you see 100 different spices or 100 different crayons. So you give these crayons to one person and it's so ugly of a picture, and you give it to another person and he uses only 3 or 4 and it's so beautiful. Same with spices. So we really need to know when we're mixing these medications, we're mixing the medications that will really augment each other with little side effects. There is also, sometimes we call it first-line therapy and first-line medications and medication that we use in certain conditions. So the classes of the medication that we use as a first line called angiotensin receptor blockers. These medications have the least side effects and the most tolerated, and patients will adhere to the most. And they have a very good cardiorenal and actually retinal protective effect because they have a microvascular and endothelial protective effect. There's now work to see if these patients will, these medications and this class of medications will impact the course of diabetic retinopathy as well. These are the TANs, losartan, valsartan. These group of medications, fortunately, 2 now or 3 have become generic and they become easily accessible by patients. Less tolerable but also very good medications are the prils. The lisinopril, the captopril, these medications are also cardiorenal retinal protective, and the government have made it so easy that they give them free at Publix, free at different entities. You take your prescription, go to Publix, say I have high blood pressure and my doctor gave me lisinopril. So the pharmacist will take a prescription, give you 30 pills and say here's your medicine, complement of Publix. So the reason is that these medications can impact cardiovascular disease so much and renal disease as well. So now we have them free. The next class of medications, if your blood pressure is not well controlled, then we add a diuretic. And the diuretics are usually added when patients have difficulty with swelling, they're on a high salt diet, or they have salt sensitivities. Some families have salt sensitivities, some ethnicities have salt sensitivities. African Americans have a lot of salt sensitivity. They respond very well to diuretics. On the other hand, there are some white families, they will drink the seawater and never have hypertension. Why, we really don't understand, but we observe these observations. When we give diuretics, those patients will have cramps, will have their potassium will be reduced. So we encourage patients either to eat bananas, tomatoes, or take their potassium pill. The next group of medications called the calcium channel blockers. Those medications are like the Norvasc, amlodipine. They lead to edema, tachycardia. One of the side effects that really pertain to you is relentless headache over the temporal artery. So a lot of times patients will come to you and say, okay, this patient is complaining of this headache and tenderness over here. Do they have this? And this workup, cascade of workup of temporal arteritis is initiated, but this could be a side effect from Norvasc. Now, the beta blockers end up with the LOL, and this is not a text LOL. This is the metoprolol, carvedilol, atenolol. Those medication can lead to fatigue, and really patients do not like them. The reason is they cannot do what they used to do. It's just like you're turning the RPMs on your engine from 400 to barely 104. So you cannot do anything. Your life is very slow. And that's how they really control the blood pressure, because everything is so relaxed. One of the major side effects is actually erectile dysfunction. So when I choose an antihypertensive agent, I look at my optimal choice and the optimal combination. It has to be effective and reduce blood pressure, because that's what my objective is. I want to give you a pill that I know it is dropping your blood pressure, and a drop in blood pressure means survival. And I'm wanted to give you a pill that I know it will make a difference for you if you have a diabetic kidney disease, if you have diabetic retinopathy, if you had a stroke, you had a heart attack. I want to really consider your comorbidities. And I do not want to give you the same medicine that has same class of medication but different pills. We have to have medication that have augmenting mechanism of action. And if I give you a medicine that is $700 a month, you're not going to take it. So the pills, the cheap medicines that work, really we have to consider that in this economic difficulties, and they have to have a favorable side effect profile. If we give them a medicine and they don't take it because they hate the side effects, then you know you're not doing your patient any service by knowing that, doc, I can't take this pill, is doing this for me and that for me. One of the, I'll give you an example, other than the beta blockers and erectile dysfunction for men, one of the medication lead to increase hair growth. It's called minoxidil, and that's the basis of the medicine for people like me, for male pattern baldness. But if women have resistant hypertension and you give that to a woman and the next thing is a beard bigger than me, you think she's going to take that medicine? The answer is no. So keep in mind, we have to give a medicine that works, medicine that has augmenting effects, and they can afford it, and has the least side effects. With this, any questions or comments?
What are some of the most popular diuretics?
So the good question, what is the most popular diuretics? And that is a very good question. The ones that are used for hypertension, the most common one is called hydrochlorothiazide, or HCTZ. And that is really a mild diuretic, make you get rid of the sodium more, so it's not like when you take it, you have to rush to the bathroom. Other diuretics like the Lasix and its cousins, those diuretics are good for heart failure. So those will make you have brisk diuresis, whereas remember, hypertension is a sodium issue as well. So the hydrochlorothiazide, the chlorothalidone, those medications have to be combined with potassium as well.
Do some doctors prescribe that as
Hydrochlorothiazide, it depends on the patient, whether they have edema and what is their ethnicity. And remember, it has to work, it has to be cheap, it has to have little side effects, and consider other comorbidities. So some physicians prescribe that as a primary, yes. Yes, sir.
You might mention lisinopril, the main side effect is coughing.
Yes, thank you very much for bringing that to attention. The main side effects, that happens about 10% of the time. Patients will have cough, resistant cough, and it's a dry cough. And one of the patients one time came to me and he was coughing, and his comments were, "Doctor, I have bad bruises on my back from my wife elbowing me all night from coughing so hard." So that is one of the side effects as well. And that happens in about 10% of the time. Yes, ma'am.
How involved are physicians like you who primarily study blood pressure with glaucoma management? Because I'm learning a lot more about intraocular pressure as it relates with our systemic blood pressure as far as damaging nerves. So do you have any studies, or do you involve yourself in that at all?
There is very little. Most physicians consider the eye as this, most practicing physicians other than ophthalmologists, the eye as this organ that sits right there in the corner by itself, and we really, you put glasses on it or lenses or make color lenses, and that's about it. But physicians who really recognize that the eye is the window to the heart and to the kidneys and to the blood vessels and to the brain as well with the papilledema, will really sharpen their skills. So as physicians training in the medical fields, we really are not taught that aggressively to utilize that window. But now we know today some of the diuretics like Diamox is used in glaucoma. I have seen cases of profound bradycardia related to timolol with glaucoma. I have seen case of prostate urinary retention from Zalatan for glaucoma as well. So really we know, but the relationship to be that concrete has not been established yet. And you have to really, as a physician like myself, to have an interest and train yourself to learn, to recognize that the eye is the easiest way that you can see the innards of the vasculature. There was another question? Yes, ma'am.
Recommend vitamin K2 is with relation. You mentioned vitamin D. Does K2 ever come up?
Vitamin K and is now recognized as an anti-thrombotic agent that the research, and it's mainly not scientific research, but really in the alternative medical therapies arena, is now gaining some momentum. It doesn't hurt, so when people ask me about alternative medical therapies, I say, as long as it doesn't hurt, I don't know if it's good, so you can take it at your own risk. If it hurts, like for example, there are some medications, Chinese herb to lose weight, absolutely not. Renal failure, hypertension. So there are things that I am totally against. There are things that are neutral, and there are things that I encourage. This is one of the things that I am neutral about, because we don't know if it helps, but it doesn't hurt as well. So if it's not that expensive, I've seen patients spend $300 a month on these vitamins and replacements, and they order online. And I mean, this is, it's a $12 billion industry, alternative medical therapies. Yes, ma'am.
On vitamin D, if you're borderline or a little deficient on your vitamin D, a little prehypertensive, would you give the patient 2 or 3? D2 or
Okay, that's a very good question. I have another full lecture on vitamin D, but I'm going to answer briefly. So the question is, should you get D2 or D3 for vitamin D replacement? Well, we don't make vitamin D2. The vitamin D2 comes only in a bottle or when you irradiate certain mushrooms or the milk. That's when you make vitamin D2. We use vitamin D3 and we utilize vitamin D3. So I don't prescribe D2. I prescribe mainly D3. And if somebody, and I have a different way of looking at things, if your level is borderline low and the range is from here to here, I don't want you to have just a borderline above the norm. If you're having diseases, whether you're having aches and pains, diabetes, prediabetes, hypertension, obesity, tiredness, fatigue, I want you to be right here. So I push the levels up to the near upper normal rather than right barely above the normal, which is a different philosophy because I can see you suffering when you're barely below. If you're asymptomatic, it's a different story. But you tell me you're pre-diabetic, pre-hypertensive, knees hurt, back hurts, I'm tired, I'm depressed, I can't do this, I can't do that, I want you here rather than here.
What's the typical daily dosage that you recommend?
It depends on the level, but a safe dose is about 2,000 international units of D3 a day. And that is a very generic dose. It's not going to be too much, it's not going to be too little. But if your levels are lower, you may need more, and that needs a visit to the doctor to measure your D level. I hope I was able to keep you awake after the heavy lunch. Thank you so very much.